Hello, everyone. My name is Jim deMaine. I'm a retired pulmonary critical care physician. And for many years, I've been writing a blog about my experiences in the intensive care unit, particularly around the way people die and how they handle death. And recently, I've published a book called Facing Death, Finding Dignity, Hope, and Healing at the End. And what I'd like to do is read you a few passages from the book and then show you a few slides about my take on these issues. And thank you very much for listening because this is obviously a difficult subject for us all. But I'll start with the introduction. For 38 years, I cared for very sick, terminally ill patients. Their stories, their deaths and suffering have become part of me. I have collected and treasured the many kind notes that patients and families have sent me, at times crediting me with powers I do not deserve. As I ministered to patients, their loved ones, and caregivers, I was part doctor, part teacher, and part spiritual advisor. In a care conference in the ICU, I would often tell a story to help a family understand the crisis their loved one was enduring. I tend to think in stories and found that through them, families could more easily grasp whatever lesson I was trying to impart. They, like most of us, had not talked about death and were unprepared for it. But when death lands on our doorstep, do we lock the door or welcome it in? Dying is different for each of us as we enter the unknowable on our own unique path. Sometimes we negotiate. Larry surprised me during a visit to my pulmonary clinic. And I'd like to just tell you the story about Larry because he was fairly unique in the very direct way he communicated with me about how he would die. Larry had very severe advanced chronic obstructive pulmonary disease, COPD. And over time, although he had stopped smoking, his symptoms worsened and he required multiple hospitalizations for flare-ups. And during these, he was so uncomfortable, gasping and terribly distressed and shortness of breath. And despite the fact he was on oxygen and prednisone, he knew that his time was short. He was kind of a crusty guy and a super salesman. And one day in the office, he told me, "Hey, Doc, I would like to take you out to lunch." I was a little nervous that he was going to try to sell me something, and the way he was. He wanted to talk to me about the way he wanted to die. So I did agree to go out to lunch, and after some niceties, he said, excuse me, "Hey, Doc, I want you to help me at the end. I've really been suffering. My quality of life has deteriorated. And I just can't go on this way. I need you to help me at the end. I don't want to keep going through this." So I said, "Well, Larry, there are some things we can do. We can give you morphine at the end." And he said, "Well, what would morphine do?" I said, "Well, it would give you a sense of euphoria. It would sedate you, would take away your shortness of breath and make you at peace." And he said, "Well, that's fine. That's what I would want." I said, "Well, there's a downside to this, Larry. It could hasten your death by a matter of hours or even days." And he said, "That's not important to me. It's my quality of life is just so terrible right now." And I said, "You need to talk this over with your sons and hopefully get buy-in from them and then communicate back to me." So we touched base a few weeks later and his sons were on board. And then things were fairly quiet until one evening around dinner time, I got a call from the emergency room that Larry was there. He was not doing well at all, and they wanted to put him in the intensive care unit. And I said, "I'm not sure he wants to go there. Let me come in. Let me talk to him a little bit more." So I met up with Larry in the ER, and he looked me in the eye and said, "Remember what we talked about?" He was getting pretty blue. He was very, very uncomfortable. So I did review the plan with him and admitted him to the medical unit. not to the intensive care unit. If we go into the ICU, we generally are signing up for a lot of technology. We probably would get a ventilator if one was indicated, and if our heart stopped, we would get all means to get it restarted again. And Larry didn't want that. And I met up with nurses on the medical floor, and fortunately they were very experienced senior nurses, and they were willing to go along with the plan of giving him incremental doses of morphine, titrating his symptoms for control. And that's basically what we did. The sons were there, and I left, and about 3 in the morning, Larry departed from this life. Later, I got a very nice note from his sons saying if Dad could, he would come back and shake your hand. Thank you for all your care and help. The care of Larry brings up an interesting ethical point. Was I actually practicing euthanasia or not when I agreed with the plan to give Larry morphine? And basically, this is not euthanasia. This is what we would call now aggressive palliative care. By giving the intent, by giving him these medications was to relieve his symptoms, not to cause his death. And that's a very important distinction. It's called the double effect. And that concept has been supported in legal case in the reasoning that was in a Supreme Court ruling. So Larry had a peaceful end, but we don't all have a peaceful end. And in my book, I do describe a wide variety. I'll read you a little bit more here. In this book, I present my own stories, lessons learned from patients like Larry and many others who taught me about dying. My medical career began in an era when little could be done for two of our greatest killers, heart disease and cancer. There were no ventilators. I often saw patients die without the benefit of hospice care. ICUs and CCUs had not yet evolved, but with amazing rapidity, medical science has brought us life-saving advances such as hemodialysis and organ transplants. This progress is both marvelous and problematic as technology continually outpaces our ability to thoughtfully and ethically bring it to the bedside. When should life-prolonging advances be used? How do we decide how to allocate these tools when resources are scarce or prohibitively expensive? My stories are about hopes and fears common to us all. They are about the ethical dilemmas I encountered and moments that have humbled me. They address advanced care planning, medical aid in dying, conflicts, medical mistakes, spirituality, modern hospice, and palliative care. In the last section, I share my thoughts about resilience and leaving a legacy to our loved ones. As I wrote about these patients and my experiences with them, memories surged to the surface of my thoughts, often bringing up deeply rooted feelings of sadness and joy, even fear. Did I do the right thing? Was I losing empathy? I hope as you read these stories that they encourage you to talk to your loved ones about your own hopes and fears. My greatest wish is to generate some much needed conversation about the inevitable and the choices we must consider. There is no easy way to put it. To ensure that our autonomy is respected, each of us must choose our path at the end. Before I show a few slides, I'd like to talk to you about a neighbor of mine that developed prostate cancer and had a term that I think is unusual, but I would term it a healing death, that my friend and neighbor Pete had a healing death. Unfortunately, his prostate cancer had already spread, so surgeons did a wide exploration, removing as much tumor as possible. Then over the next months, Pete took drugs to block testosterone, but his PSA kept rising, so he started chemotherapy. After 2 months of this therapy, Pete looked terrible and was admitted to the ICU for severe electrolyte imbalance. Once home again, he sat in a reclining chair that he never left except for trips to the bathroom. One day over the backyard fence, Lucy, his wife, let me know how badly Pete had deteriorated. I made a visit to his home. In their living room, I found Pete pale and clammy with a pulse, which I surreptitiously checked, of 130. Outside later, I asked Lucy, what's the plan if Pete's condition becomes critical? Well, he doesn't want to be resuscitated, so I won't call 911, she said. Have you contacted hospice yet? None of the doctors have mentioned hospice. This didn't surprise me. Doctors start off on a curative path and find it difficult sometimes to acknowledge that a patient is dying. It can be hard to step back and simply allow death to take its course. Sometimes the patients and family are ready for that shift before their doctors. In Pete's case, no one was talking about the elephant in the room. So I said, Lucy, please call your doctor and hospice soon. I brought over a POLST form, that's physician orders for life-sustaining treatment. I brought the POLST form over and told her, you really need to discuss this with Pete and his medical team. It can state very clearly that he does not want CPR. Hospice arrived the following day. They set up a hospital bed and commode. The family became caregivers, and within a week, Pete died. But I could not help wondering how Lucy would have handled all this without an informed advocate. At Pete's memorial, I asked his son, Don, how's the family doing? Pretty much okay, Don said, and then he recounted the story. Don and his father had gone for a drive when Pete was still able, and they talked about his dying. So this is Don talking now. Dad said, listen, dying is easy for me. I'll just be gone, but I'll need you to help hold the family together. I don't want you to grieve a long time. I'll be okay wherever the Lord takes me. You're a good person, and your mom and sisters are too. Things will be all right. Make my memorial a joyous occasion. It's all for you, not for me. As I listened to Don recounting this conversation with his father, I felt I could see Pete trying to put his impending death in perspective. He didn't want anything left unsaid. He didn't want his family to worry. He was, in this way, caring for his caregivers and trying to make his death an occasion for healing rather than unbroken suffering. As we are dying and beginning to shed our physical connections, we naturally worry about those left behind. But by connecting with them, talking, and planning for the end, our death can counterintuitively become restorative, healing for our survivors and for us as well. There's the passing of the torch. This is what Don had experienced in a conversation with his father. I thought of him as a kid I once coached in baseball. Now suddenly Don was a man, perhaps even more so, with the death of his father. Out of death came these new roles, new responsibilities, dare I say it, a new life. If we can accept this, there's the possibility of a healing death. While we may never truly get over the loss, a healing death helps lead us toward resilience and a sense that the lessons of life and love that have been passed on can help us move forward. So at this point, I'd like to share a few slides. This is the cover of the book. I should mention that the forward to the book is by Dr. Eric Larson, who headed up the Kaiser Research facilities in Washington State and has been on the faculty of the University of Washington. So denial is a state that most of us live in. William Soren said everybody's got to die, but I've always believed an exception would be made in my case. And denial is okay. It's healthy. That's the way we get on with living and not contemplating death on a regular basis. but it is there, and periodically it's probably a good idea. I think definitely a good idea to think about it. And this is from the Onion Humor magazine, just reminding us that world mortality remains at 100%. I didn't update the slide, but I don't think it needs to be updated. So how about advanced care planning? When we periodically think about it, we do have healthcare rights and of course responsibilities as well. But we have a right to make decisions about life-saving treatment. In Pete's case, my neighbor, he had certainly made the decision that he didn't want life-sustaining treatment. And we also have a right to inform our healthcare providers about our preferences for life-sustaining treatment. We can now go in on an annual visit if we're Medicare age to discuss this with our doctors in the annual visit, or it's allowable now to have a special visit to discuss end-of-life issues with your provider. The patients that did well and had what I call a good death have done this kind of advanced care planning. There's a website called the Conversation Project and another one called Prepare for Your Care that I list in the book that have all the necessary forms that you could use, and also a lot of other information. So when you think about this, you have to think about if you become old or sick or near the end of life, where do you want to be and who do you want to speak for you? I think if you have one takeaway from a conversation about this is finding your advocate, somebody that's close to your heart, somebody that you trust, somebody that can be there, and somebody that is willing to truly stand up for your rights and your wishes. So what's an acceptable quality of life? Well, Pete had mentioned that he did not want a ventilator, and my patient with COPD as well had said that he did not want this kind of treatment. But what are your biggest hopes and what are your biggest fears? Is it pain? Is it being alone? Is it not having family nearby? Is it not being able to say you're sorry? What are the issues that you have? And each one of us is on our own unique path. So what is a good death? Well, we need preparation, physical, emotional, and spiritual. We want our wishes honored and to have a strong advocate. Of course, pain and symptom control and completion of goals. There can be all kinds of goals. Mention one unfortunate young woman with cystic fibrosis in my book, and her goal was to go to the senior prom. Others of us might want to witness the birth of a grandchild or have a special anniversary. And Katie Hafner in the New York Times wrote a piece recently on people wanting to stay alive long enough to vote in this last election. It's an interesting goal that these people had, and one that many of us would want, I think. I think we would like to leave a legacy, some values or thoughts for those following us. And I think all of us would want to be at peace, surrounded by loved ones. So most of us won't be dying of COVID during this terrible COVID epidemic we're having now. Most of us will have cancer or heart disease, the two most common killers, and will undergo a gradual decline in health. But at the end, where you can see death on the right-hand side of the slide, this is a difficult decision because here we have to decide enough's enough and we need to let go. There is always more technology trying to keep us alive, but it's technology that we may not want that actually could prolong our death rather than provide the kind of care that we would want in terms of survival. There are really three pathways that are in our advanced directives. We are all signed up for life-prolonging care in our modern society. If we are out and have a heart attack and go down, no matter where we are, a stranger can come along and begin cardiopulmonary resuscitation, can bare our chest, begin heart compressions, and if a defibrillator is present, shock our heart. This is all built into societal norms, unless we have a way of saying that we want some of the other choices. Might be selective care. I would want antibiotic, but I certainly wouldn't want a ventilator. Those kind of things we need to talk over with our physician, depending on our health and our wishes. And lastly is comfort care. Almost everybody that goes into hospice would choose comfort care. In terms of whether we would choose CPR, as we become really elderly and frail, the results of CPR are quite poor. If we're frail and elderly, only 5 out of 100 survive. For those with advanced disease, it's only 1 out of 100. So I would like to stop the slide share here and read you another story or two. This one is about a lady who approached me after I'd given a talk in the community, which I do frequently, who said my husband didn't want this. Howie was a voted outstanding teacher of pediatric residents year after year. He was a colleague of mine. He was a walking textbook of classic diseases such as childhood measles, mumps, and whooping cough. Over lunch, he'd rail against the ways allergists tested kids. Can you believe they tie them to a papoose board, inject all these allergens up and down their back, look for swelling and redness, and call it positive? He'd cry. Then they put these kids on dust and mold shots. Howie loved the science of medicine, but his greatest passion was his patients. He had an amazing rapport with children. One mom told me that Howie would all but ignore her in favor of hopping up onto the exam table to blow up a balloon and start talking with her 6-year-old. Kids loved going to see Dr. Howie. He retired about 10 years ahead of me and we lost touch. Then one day I got a call from Howie's wife, Jeannie. He'd had a severe stroke and was in a nursing home. I don't know what to do and I really need some help, Jeannie said. Howie keeps getting pneumonia. He's confused and can't move his right side. Could you visit him? I asked Jeannie how she was holding up. Not very well, she said. I feel so badly for him. They put in this feeding tube, which I'm pretty sure he wouldn't have wanted. One thing just led to another during rehab, but he's not making any progress. We chatted some more. As his spouse, Jeannie was Howie's advocate by default. Now he wasn't able to make his wishes known. He had not completed an advance directive. Nursing homes are often called God's waiting room, and in a way that's accurate. Many residents exist in a sort of limbo state, out of sight, out of mind. When I went to visit Howie in his nursing home, he lay propped in a bed, his jaw slacked, his right eye partially closed. He did not respond to my hand squeeze. The nurses had been unable to rouse him. There wasn't much for physical therapy to do except for passive range of motion exercises. I spoke with Howie's neurologist. The prognosis for meaningful recovery looked bleak. Again, Jeannie said, I know he would hate being like this, but I feel guilty if I had the feeding tube stopped. I don't even know if the facility would allow that. We found a quiet place to talk. Howie and Jeannie's 2 grown sons joined us. Fortunately, all 3 were in agreement. Howie would never wanted to have lived like this. Together, they developed a picture of what he would wish for, what he would say if he could, and how he would love them for listening. They talked with their minister, a close friend, a social worker, and their doctor. A week later, after the feeding tube had been removed, Howie died peacefully. It was difficult in the situation because Howie had not had an advance directive and the family needed to make what we call substituted judgment. I think they did know him well enough, and probably he had talked about his quality of life, but he never made it explicit. So it made it hard on the family, and we do have technologies like tube feedings now to keep us alive, but do we really want that? It's hard to know. Um, I'd like to read yet another story. It's called A Body for the Morgue, Please, and it's on page 153. So this is about our nurses in the intensive care unit, and they told me this story when I walked in the morning one day. Cheryl and Susan arrived at the hospital at 6:30 a.m. As was their routine, they stopped for a latte at Starbucks and shared family stories as they walked toward the ICU. The two were well-known pranksters, but widely respected as top-notch nurses. The ICU, like many high-tension workplaces, can function like a family. In ours, the whole crews went to baseball games, shared picnics, and vacationed together. Cheryl and Susan were laughing as they walked into the ICU to meet up with the night shift, but they immediately sensed something amiss. Room 3 was a disaster scene. A crash cart was there with the defibrillator paddles out. All drawers had been pulled open with multiple vials and kits removed. IV poles, procedure trays, towels, drapes, and instruments indicated a heroic but failed effort to save a patient who was now under a sheet on a gurney. The night crew looked devastated. This 32-year-old woman had been admitted with severe sepsis, Carol said, the night lead, catching up Cheryl and Susan on the situation. It was probably an abdominal abscess that ruptured. Then she bled, went into shock, and we couldn't even get her stabilized for surgery. She died about 2 hours ago. Her family was a mess, and so are we. Cheryl and Susan immediately jumped into professional mode. What can we do to help? You have a bunch of calls to make and lots of charting to do. What can we take off your plate? The best thing for us now would be if you could take the body to the morgue while we finish up here. We hate to ask, but no problem. We got it, said Susan. Both nurses were relieved that the family had already left and that they were unlikely to bump into visitors. They could see the form of a fairly small woman under the sheet, but neither of them wanted to look. They were familiar with death, but this case was different. With a young woman on the gurney, it felt close to home. They were silent in the elevator as it took them down to the sub-basement where the cold lockers in the morgue were located. The long sterile hallway leading to this area in the bowels of the hospital was dim. Rubber wheels of the squeaking cart, the only sound. Then they heard the noise. Oh, it moaned. They stopped and looked at each other. Gases can escape from a deceased body, and that sometimes makes a noise, but this was weird. So they proceeded. Another 15 feet down the hall, the noise came again, even louder. And then it was quiet. As they approached the morgue doors, it came again. And the body began to sit up. Cheryl and Susan had had enough. Screaming, they both ran, leaving the body now upright on the cart. They tore down the hall straight into the arms of their colleagues who were breaking up with laughter. The body, a colleague, climbed off the cart and came running after them with glee. Gallows humor is endemic in many high-stress occupations. Fire stations, police precincts, and newsrooms are famous for it. If we can laugh, it seems, we can work through the conditions that might feel daunting otherwise. I often think of George Bernard Shaw, who observed, life does not cease to be funny when people die, any more than it ceases to be serious when people laugh. I'd love to read you more stories from the book, but I think that's probably enough for now. The book is available at your favorite bookstore, and I'd certainly love to see bookstores supported. It's also available on Amazon. I'd like to thank Clyde Hill Publishing for helping out so much. Greg Shaw, the publisher, and Claudia DeRay, my editor, helped me to put my stories together and make it a more cohesive book. People ask me who the book is for. I think it can be for anybody. Young people tend to look at living and not dying, but often families have a grandparent or a parent or aware of somebody that passed away recently. And I even had a friend give it to somebody who was dying who felt the book very supportive and restorative. So hopefully you'll consider reading, and I'd love to get feedback. Again, thank you so much.